Radiology, Harvard Medical School, Pediatric Radiologist, Massachusetts General Hospital, Boston, Radiology Training, Amsterdam, the Netherlands, Fellowship, UCLA, Los Angeles. Thanks.
Thank you very much. It's a pleasure for me to be here at this meeting, and I would like to thank Dr. Pedro Dalto for inviting me, giving me this opportunity to visit this beautiful city. My lecture today will be about evidence-based criteria for imaging of chest infections. And we will be talking predominantly about pneumonia, which is an infection of the lower airways and air spaces, either viral or bacterial in etiology. And it's important to realize, as in all of pediatric radiology, that the response of the organ, in this case the lung, is very much age-dependent, more so than dependent on the organism. So in younger children, we see different pathologies than in older children, and the findings are often non-specific. We look at complications of pneumonias, effusions, clear effusions, parapneumonic effusions, and empyemas, lung abscesses, and necrotizing pneumonia, and then complicating factors such as the virulence of the organism. Multi-resistant Staph aureus is one of them, which have come up in the community. Immune deficiencies of children and altered anatomy and function, such as patients with congenital lung malformations and cystic fibrosis. The epidemiology, pneumonia is a very large entity, more than 150 million cases per year in children under 5 years in the world. In the United States alone, there are 20 million hospitalizations per year. And the prevalence is 5 to 10% per year in children under 5 years. Effusions are occurring about 1/3 of patients who have pneumonias. Most of them, the majority, are clear parapneumonic effusions, and only rarely does an empyema result, which is a complex organized pleural effusion, basically an abscess in the pleural cavity. However, the incidence of complications of pneumonia is increasing over recent years. I also looked up some literature about the burden of pneumonia in children in Latin America. Almost 2 million deaths in children under 5 years. 70% of those deaths in developing countries are caused by pneumonia. And the mortality of pneumonia varies as low as 2 to 10% in countries like Chile and Uruguay, and as high as 15 to 20% in Bolivia, Peru, and Guyana. And Brazil takes in an intermediate position. So it's a very large problem, a lot of reasons for medical imaging. This is just some other parameters. This is the probability of boys dying before the age of 5 years per 1,000. You can see how the different countries vary, with the largest mortality in Bolivia. And Brazil takes an intermediate position. And this parameter correlates very highly, as I said, with the mortality due to pneumonia. Also, infant mortality rates are quite variable over the South American region, with Brazil taking an intermediate position here. Risk factors of pneumonia, particularly is focused on Brazil. I looked at a prospective cohort study in Bahia, Salvador, published in Brazilian Journal of Infectious Diseases. Pneumonia is associated with a high rate of malnutrition and chronic disease, and findings on physical exam include tachypnea, chest indrawing, and somnolence in hospitalized patients. There's a case control study in Fortaleza, published by Dr. Fonseca in the World Health Organization Bulletin, and again confirms a high rate of pneumonia associated with malnutrition, low birth weight, attendance of daycare centers, and crowding conditions, and also non-breastfeeding, high number of pregnancies, incomplete vaccination status, but surprisingly, there was no correlation with socioeconomic status. There's some papers describing an increasing incidence of Legionella, unusual bacteria in certain population, Rio Grande do Sul, 5% incidence of pneumonia in young children. There's also a high prevalence of AIDS-related pneumocystis infections in children reported in Brazil. There's a case report about idiopathic hemorrhagic pneumonia that surfaced in 2006. Cause was never found. The effectiveness of the H-flu vaccination has been investigated in this paper, and it is found to be 31% effective in preventing pneumonias. And finally, there's a report about hantavirus pulmonary syndrome in Brazil. And some images I borrowed from that paper. It was predominantly a progressive disease with rapid mortality. And on CT, we can see this miliary pattern of disease and alveolar pattern in the lung. So cost of society from complicated pneumonias in Europe, 1.1 million adults per year, leading to a cost of 8 billion per year. In the United States, pneumonia is a frequent cause of hospital visits, antibiotic use, and loss of work days. Pleural complications, this is a paper that specifically discussed the cost effectiveness of thoracentesis, thoracostomy, and video-assisted surgery compared to conventional chest tube placement, and found them to be equal in cost effectiveness, but video-assisted surgery has the shortest hospital stay. In Brazil, I found a figure of only $136 per hospitalization, which is surprisingly low compared to the cost of even seeing a doctor in the United States, which is higher than that. So obviously the public health system in Brazil is doing a very good job in salvaging those patients who come to the hospital with pneumonia. Once a child is hospitalized, the prognosis is very good. So the goals of imaging is early diagnosis, particularly in immunocompromised patients, diagnosis of underlying anatomic abnormalities, and the detection of complications, and finally the guidance of treatment. The clinical diagnosis depends on the age of the patient, as I mentioned earlier. Neonatal bacterial pneumonias are more common. Then the level of antibodies from the mother goes down. And so between 2 months and 2 years, viral pneumonias become more prevalent because of the lower antibody levels in the infant. And then over 2 years, bacterial pneumonias become more prevalent again. Symptoms are often non-specific: cough, respiratory distress, fever, temperature instability, and leukocytosis. The clinical diagnosis of pneumonia, several papers, tachypnea was found the most important sign for the diagnosis with a fairly high sensitivity and specificity. And if all 4 symptoms, fever, cough, sputum production, and dyspnea are present, there's a high sensitivity of the clinical exam. But those 4 symptoms are not always present, of course, so that's where chest imaging comes in particularly chest radiography. What is the sensitivity and specificity of plain radiography for the diagnosis of pneumonia? And these figures are fairly good of all these various authors. Plain radiography is sensitive enough to diagnose most pneumonias and specific as well. So what is the role of radiography? First of all, to confirm the clinical diagnosis, sufficiently sensitive and highly specific. An interesting outcomes paper suggests that if pneumonia is diagnosed under 5 years in an ambulatory setting, in other words, no hospitalization is needed, routine chest radiography does not improve the outcome, which is an interesting finding, I thought, because once a patient is hospitalized, of course, a chest X-ray will be taken, but there is no need, apparently, for chest X-rays in the ambulatory setting. Using evidence-based criteria, one can reduce the need for imaging whenever there's first-time wheezing episodes or family history of asthma, particularly when wheezing is part of the clinical presentation. That's also emphasized in a paper this month in the July issue of Pediatrics. If wheezing is a feature, then there's unlikely to be found a bacterial pneumonia, and chest X-rays may not be indicated. There's a specific group of patients with fever of unknown origin under 5 years of age and leukocytosis, and those 19% have an occult pneumonia, and in those patients, chest radiography is thought to be evidence-based indicated. And then the role of radiography is also to look for other causes of the respiratory distress and complications. Important clinical distinction, viral versus bacterial, relies on the age of presentation, as I mentioned, the presence of fever, which is not a very good diagnostic differentiation, higher fever usually with bacterial, but also high fever seen with viral infections, localized symptoms most commonly with bacterial infections, pleuritic chest pains usually seen with bacterial infections, wheezing, rhinorrhea, and congestion usually in viral infections, and then lobar versus alveolar presentation on the chest X-ray, which has some predictive value but not a clear distinction. So what do we see on chest X-rays? We see features like hyperinflation, increased perihilar lung markings, and it's often difficult for us as pediatric radiologists to predict whether this patient has a viral or a bacterial pneumonia. This patient turned out to have a respiratory syncytial virus infection with hyperinflation of the lungs, a fairly typical radiographic pattern, no need for antibiotic treatment. This patient, on the other hand, had relatively normal lung volumes, but still had RSV bronchiolitis with superimposed atelectasis. Most radiologists would describe consolidation in the middle lobe, but nonetheless there is no indication in this patient for treatment with antibiotic. This patient, on the other hand, had extensive airway disease, had to be intubated in the hospital, and was diagnosed with pneumocystis infection of the lungs. So there's an overlap of radiographic findings, and we're not always possible to predict which patients require antibiotics. Communication of our findings is very important. In a recent article in Pediatric Radiology, when we mention in our report peripheral airway disease, the pediatricians understand this to mean viral pneumonia in 62%, asthma, and they even consider it a normal finding, so they would not give any treatment. If we talk about focal airspace consolidation, which I thought means pneumonia, most pediatricians actually consider this to be atelectasis and also pneumonia. When we use the word focal infiltrate, a term that's discouraged by radiology training programs, most clinicians at least understand this is a pneumonia and likely a bacterial one. So the treatment is dependent on whether antibiotics or anti-asthmatics have to be given or no treatment at all. And in our reporting, we have to be very specific as to what we see in order to help the clinicians guide their treatment. Complications of pneumonia, necrosis and abscess, loculated effusions, empyemas, and bronchopleural fistulae. These are usually indications where CT is indicated. Opportunistic infections as well with a depressed immune system, fungal pneumonias and pneumocystis infections. CT has proved added value. And then the multi-resistant Staph aureus infections, which are coming up in the community due to overuse of antibiotic. CT is also helpful. CT is more sensitive than radiography. So of course CT is more sensitive, we all know that. It is a more sensitive modality inherently. In this particular patient, opacification of the right hemithorax. Decubitus radiography is not very helpful because there's not much aeration in the right lung. CT shows very clearly the air bronchocrams, the consolidation in the lung, and also the pleural collections with compression of the lung parenchyma, which is a very important sign. When the pleural space is under pressure, you see a convex margin. This is an empyema that required specific drainage. So do we have to do chest CT for every case of pneumonia? Of course not. It's not cost effective. CT is a very high-tech modality. It is certainly a good tool. It's a fast tool to perform. It often can guide treatment decisions. But whether it's cost-effective or not, that depends on your local situation. In the United States, it's frequently done because the cost of hospitalization is so expensive. In Brazil, with the cost of a hospitalization for pneumonia of only $136, a CT scan may not be cost-effective. Because the CT may be more than the whole hospitalization in terms of dollar amount. Here we can see the use of CT for diagnosing an empyema. CT should be done with contrast administration. One can see the enhancing pleural membrane. It will be drained with chest tube placement, and even after the treatment there may be thickening of the pleura which prevents full expansion of the lung. And CT can be helpful in those cases. As a matter of fact, ultrasound has been proven more effective and more cost-effective than CT in the majority of pleural complications of pneumonia. And it can guide image-guided treatment, early thoracostomy, and thoracocentesis. Fibrinolytic treatment has been used through the thoracostomy tube, but there's insufficient evidence in the literature that this is cost-effective. So there's still controversy in this particular area, where the fibrinolytics are indicated. And also whether the video-assisted surgery that is nowadays done by pediatric surgeons is better than image-guided treatment. This is still controversial. There's many papers in the surgical literature that suggest early surgical intervention is cost-effective, but they haven't compared it with image-guided treatment in an optimal way. So there's still need for evidence-based papers to be written. Ultrasound is certainly the most effective way to diagnose a pleural effusion. It's been emphasized in previous presentations as well. We can see the loculations in the pleural fluid and the debris, and it can definitely guide treatment decisions without a need for CT. And this patient underwent video-assisted surgery of the pleural space with placement of a chest tube, mainly based on the ultrasound findings. So our algorithm that we propose for immunocompetent children with suspected pneumonia and associated effusions is to do ultrasound first. If the ultrasound is simple effusion, we recommend medical treatment and supportive treatment only. If there's a complex effusion, one can go straight to drainage of the empyema or do a CT first, but this is actually a very cost-effective way of doing it. Draining it under ultrasound guidance. If the patient does not recover with medical treatment, then a CT could be done in a later phase. And these are the surgical options for treatment, and these are the medical treatments. We have to decide, based on our imaging, whether parenchymal opacities are pleural-based or parenchymal-based. And here we can see clearly as a sharp margin, this lesion to the pleura, even seen on the chest X-ray. The patient started coughing up a lot of purulent material, and then we can see the typical findings of an intrapulmonary abscess, which requires usually medical treatment and not surgical treatment or chest tube placement. Leukemia, patients who are immunocompromised because of chemotherapeutic treatment require a more aggressive management. And here we can see on the CT this patient who developed an ARDS syndrome and had to be intubated, has air leak in the chest wall. CT can be very helpful in those patients to diagnose the pulmonary nodules that are somewhat specific for fungal infections and other opportunistic lung infections. And this patient was diagnosed with aspergillus pneumonia, which requires a different treatment regimen. Tuberculosis, probably more common here in Brazil than in the United States, can be diagnosed with, predominantly with CT, where we can see the intrapulmonary lesion with early calcification in addition to the hilar lymphadenopathy associated with AIDS-related complications. Congenital lung malformations. This is a patient who presented with a pneumonia with an unusual appearance in the right upper lobe. A CT was done initially. One can already see the abnormal bronchial anatomy here. The patient did respond very well to intravenous antibiotic treatment. The pneumonia almost completely clears, but one can see residual abnormalities here with hyperaeration of the lung, and a repeat CT scan shows this hyperaerated lung with diminished vascularity and the findings of a bronchial atresia with a mucocele in the bronchus. Required surgical resection of this right upper lobe eventually. And then, as been mentioned before in other presentations, specific CT manifestations of basilar lesions that persist despite antibiotic treatment, as in this patient, a triangular mass in the left lung base. We do CT angiography with opacification of the descending aorta, and we can then see the feeding arteries that go to the sequestration. So in those cases, CT is very helpful. So in summary, I would like to emphasize the role of medical imaging in the treatment of pneumonia and its complications. Plain films are really limited to differentiate viral and bacterial processes in the lung. This is a critical, important for the clinicians to decide how to treat these patients. We have certain criteria that we can use, but there is a lot of overlap between the viral and the bacterial presentations of pneumonia. So we have to look at the clinical history and come to an overall diagnosis. CT is better than chest X-ray, it's more sensitive than chest radiography for pleural complications and in immunocompromised patients. And in those patients, it's probably indicated. Whether it's cost-effective in the majority of cases depends on your local situation. How expensive is a CT? How expensive is an extra day of hospitalization in your particular practice setting? So you cannot give guidelines that are uniform all over the world in this respect. Ultrasound is definitely proven to be, based on several papers, better than CT for diagnosis and treatment planning of pleural effusions. And that's an important take-home message, I would say. An early video-assisted thoracoscopy may be more cost-effective than image-guided treatment of empyemas, but this is a controversial area that still requires further study. It obviously depends also on the local situation where you'll be working. Is your pediatric surgeon doing this kind of early interventions, or do they rely more on you as an interventional radiologist to drain the pleural fluid? Do you have good experience with the use of fibrinolytics to lyse the effusions? Then by all means, go ahead and do more of those. So these papers don't always apply to the general situation in all parts of the world. Imaging protocols that we use for chest infections rely preferentially on posterior, anterior, and lateral views of the chest, but if the patient is too sick for that, AP films are also helpful. Decubitus radiographs only when there's enough aeration in the underlying lung. Ultrasound should be done of the whole chest with various transducers. And CT should be done with intravenous contrast. and reduced radiation dose, lowering the MA, making it appropriate to the patient's body size. Z-axis modulation could be used and reduced KV in small children. Future research could aim at cost-effectiveness of CT for pleural disease, prediction of treatment success. How can ultrasound be used more in the diagnosis of pulmonary infections and pleural disease? And Dr. Goya and Riekers have showed us some very interesting examples how ultrasound is used more frequently in many parts of the world. New role of MRI. There are some papers that show that even an MRI scan can be used to diagnose empyemas and complicated pneumonia. Obviously not suitable for young children who require sedation, but it could be done in older children. It's probably not cost effective. And then there's a need for a prospective comparison between image-guided versus video-assisted thoracoscopic surgery for the treatment of empyema. Well, thank you very much for your attention. It's a pleasure to be here, and I hope you enjoyed my presentation.